effects of increased intracranial pressure on different brain parts. If there is downward displacement of the thalamus, which is in the center, it causes bilateral miotic pupil. Thalamus, it displaces down, it causes pressure on both the CN3 oculomotor nerve. It causes bilateral miotic pupil. The oculomotor nerve supplies pupillary constrictors on both sides, and it forms the efferent limb or the motor limb for the pupillary light reflex. Increased stimulation or irritation causes miotic pupil bilaterally, drowsiness and stupor. Number 2, increased intracranial pressure distorts midbrain and diencephalon anatomy, and posterior fossa mass, which causes ataxia, stiffness and nausea. That causes abnormalities of both these areas, midbrain and posterior fossa mass, distort vital brain stem centers and cause obstructive hydrocephalus and brain herniation. Now, upper midbrain lesions, they cause pupillary dilatation, whereas we just learned that the displacement of the thalamus causes bilateral miotic pupil. But upper midbrain cause pupillary dilatation because they interrupt fibers of the oculomotor nerve. Oculomotor nerve supplies the pupillary constriction, so interruption causes dilatation of the pupil because pupillodilator fibers are supplied by the sympathetic division from superior sympathetic ganglia. So upper midbrain lesion causes pupillary dilatation, loss of light reflex. Oculomotor also forms the efferent limb of the light reflex, and loss of vertical and adduction eye movement. Vertical movement to the extraocular muscle is supplied by the oculomotor, and adduction, medial rectus, also supplied by the same muscle. So there is interruption of the fibers of the oculomotor nerve in the upper midbrain lesion. Whereas if there is preservation of the light reflex intact and eye movements, the third nerve is intact with coma. So what does it indicate? It indicates widespread structural lesion of the cerebral hemisphere due to metabolic causes. Now, Uncus compresses the oculomotor nerve, but it causes ipsilateral pupillary dilation, not bilateral. A lesion of the midbrain causes bilateral, as we just learned earlier that lesion of the midbrain causes pupillary dilatation bilaterally. But a lesion of the Uncus or pressure on the Uncus causes ipsilateral pupillary dilatation because it affects the unilateral oculomotor nerve. Now, displacement of the medial temporal lobe compresses oculomotor nerve and cerebral peduncles. That leads to ipsilateral pupillary dilatation and contralateral hemiparesis. We have discussed this on the midbrain syndromes and have separate videos, so please watch them for further details. So medial temporal lobe compresses the third nerve and causes ipsilateral pupillary dilation and contralateral hemiparesis. Progressive compression of the brain stem damages midbrain, then pons, and finally medulla. So compression first damages the midbrain, then pons, and finally medulla, and then it herniates, causing respiratory arrest. An acutely enlarging mass causing horizontal displacement of the pineal gland of more than 3 mm causes drowsiness, more than 6 to 8 mm causes stupor, and more than 9 mm it causes coma. So pineal gland displacement, if more than 3 mm, drowsiness, more than 6 to 8 mm, stupor, and more than 9 mm causes coma. So what's the difference between stupor and coma? Coma is deep sleep, patient cannot be aroused, and stupor is higher degree of arousability and patient is transiently awakened by vigorous stimuli. Now next is cingulate gyrus displacement. It causes anterior cerebral artery compression. We have a separate video on brain strokes and cerebral artery compression. Please watch that. And as I already earlier explained, posterior fossa mass causes ataxia, stiffness and nausea.